This is ECG of 26 years old male with a palpitation and no other complaints or concomitant diseases. The premature ventricular contraction burden is 13.5% according 24-hour ECG monitoring. Remind that PVC burden was defined as percent of total PVC number divided by total beats during the monitoring period. Both echo and CMR without any changes. I will have a question about this case in the end of this video, so keep watching until the end. We will examine ECG by the order in the left. And first thing that we need to check is voltage and paper speed. As you see, 10 mm is 1 mV and paper speed is 50 mm per second, which means that one large box is 0.1 second. As you see, after every 2 leads, we see second standard lead as a rhythm strip. The next step is pacemaker of the heart. For evaluation the pacemaker of the heart, let's find the P wave in second standard lead and AVR. If P wave is located before QRS complex and it is positive in second standard lead and negative in AVR, this is sinus rhythm. So as a result, some complexes are definitely sinus and some are not. Next step, regularity. For evaluation the regularity, let's check the RR intervals. As we see on the rhythm strip, there are periods of net sinus rhythm. RR interval is almost equal to each other. The first one is equal 9 large boxes or 0.9 second. The second is 9 large boxes and 3 small boxes or 0.96 second. For clear calculation of difference in percent, we divide the smaller RR by larger. As a result, first RR is 93% of second one, so difference is 7%. If the difference is less than 10%, as in our example, rhythm is regular in this part of ECG. But in part of ECG, when we have non-sinus complexes, we see different RR intervals even by eye, 0.46 second and 1.22 second respectively, and difference between them obviously is more than 10%, so the rhythm here is irregular. But why? By using the RR interval from the regular sinus rhythm, let's predict when the next sinus complex should be. As we see that non-sinus complex appears earlier than predicted R wave. As a result, this is premature contraction or extrasystole. Now look at the morphology. There are no P wave in extrasystolic complex. QRS duration is equal to 1 large and 2 small boxes or 140 millisecond. Also, premature complex has discordant T wave. All of above indicates ventricular origin of premature contraction. According to premature ventricular contraction terminology, interval from the onset of previous sinus R wave to the onset of ventricular extrasystole R wave called coupling interval. Interval from extrasystolic R wave to the next sinus R wave called post-extrasystolic pause. Both coupling interval and post-extrasystolic pause form compensatory pause. That in case of premature ventricular contraction usually is equal to sinus RR interval and called complete compensatory pause. Complete compensatory pause is another sign of ventricular extrasystole. Now let's calculate our case. Compensatory pause is 1.68 second. 2RR interval is 1.8 second. As a result, in our case, compensatory pause is incomplete. That is not usual, but can be in ventricular extrasystole. Situation when every second complex is ventricular extrasystole, called ventricular bigemini. This pattern causes palpitation feeling in our patient. The next step is heart rate. For calculation the heart rate, we need 60 divided by RR interval in seconds. In our example, in regular ECG part, heart rate is equal 66 beats per minute. In extrasystolic part is equal 130 and 49 beats per minute respectively. After this, let's check the mean QRS axis. For this we need to find maximal amplitude of R wave in extremity leads. In our example is second standard lead. And also we need to find biphasic or near to biphasic QRS also in extremity leads, which is in AVL. After this we use XXL diagram and find the lead with maximal R wave. This lead indicates the alpha angle of mean QRS axis. For checking the correct evaluation, the lead with biphasic complex should be at right angle according to XXL diagram, as in our example. As a result, alpha angle is 60 degrees, that indicates the normal mean QRS axis. Next step is one-by-one evaluation of all waves and segments. All waves and segments are in normal range, so for saving your time, I will add the results of their measurements. If you need to detail check, press pause. For the further management strategy, we need to know site of origin of extrasystole. I usually use this article for ventricular site of origin evaluation. Let's go. Here we have a table of outflow tracts ventricular arrhythmias ECG features. We see right ventricle outflow tract features, left ventricular aortic sinus of Valsalva features, left ventricular mitral annular ECG features, and epicardial ECG features. Evaluation consists of extrasystolic bundle branch block morphology check, extrasystolic frontal mean QRS axis, evaluation of precordial transition zone, and evaluation of QRS morphology in some ECG leads. Firstly, check the bundle branch block morphology. We already have another videos about left and right bundle branch block, link will be in description. In V1 and V2, QRS has RS morphology with concomitant ST segment elevation. In V6, QRS is represented by white R wave. These changes are more suitable for left bundle branch block. As a result, some left ventricular origins of PVC are excluded. Next step is frontal axis. For this we will do the same evaluation steps as for classic sinus rhythm, but now for extrasystoles. High R waves are in second, third and AVF leads. Maximal amplitude of R wave is in AVF. Near to biphasic complex is in first standard lead. By using the XXL diagram, we indicate the alpha angle for PVC. Alpha angle is 90 degrees, which indicates inferior frontal axis. The next step is transition zone. Remind the transition zone is chest lead, where R wave becomes larger than S wave. In our example is V4. As a result, we excluded some other sites of origins. And all sites of origins that remain are different part of right ventricular outflow tract. Next step, QRS morphology in V1. In our example is RS morphology. Consequently, parechesion localization was excluded. Now let's check the QRS in V6. Here it represented by R wave. Next step is evaluation of first standard lead. Here QRS is mostly negative. As a result, right cusp of pulmonary valve sinus is excluded. So only two sites of origin remain. For right ventricular free wall, QRS in inferior leads should be notched. But in our example, inferior leads are not notched. So free wall localization is excluded. And one localization that remains is left cusp of pulmonary sinus, which is the most correct site of PVC origin in this case. In another outline from the same article, we have ECG example from different sites of origin, and an anatomic localization according to the base surface of the heart, where you can see the pulmonary valve and its left cusp. As a result, the correct conclusion is ventricular bigemini from right ventricular outflow tract, especially from left cusp of pulmonary sinus. And the final question, what is your next management step and how PVC site of origin defines the strategy? Write your thoughts in comments below. If you like the content, press like, subscribe to our YouTube and Telegram channel and have a good day.